So I'm advancing the slides.
Welcome to the Healthier Washington webinar. Thanks for joining us for our quarterly webinar focused on value-based payment and rural solutions to care delivery. My name is Laura Kate Bechkin, and I am the Healthier Washington Coordinator and HCA Deputy Chief Policy Officer. Next slide. Before we get started, we want to make sure that everyone's connected. We welcome many opportunities throughout this webinar today to take your questions. The way to do so is to use the questions section in the webinar panel and submit any questions that you have. We'll be collecting and theming throughout the webinar, so please do not wait until the end to send your questions. We will probably wait until the end of the presentation and leave lots of time for Sue and Gary to answer your questions today. So today we will be hearing from Sue Birch, who is the Director of the Healthcare Authority, as well as Gary Swan, a Senior Health Policy Analyst with HCA. The agenda today really revolves again around the opportunity and challenges that rural systems face, and particularly our rural providers face. We want to take you on a little bit of a journey, recognizing the complexity of rural healthcare delivery. We structured today's webinar to really paint the big picture and outline the challenges for rural providers. Second, we'll share the ways the state is investing resources to transform and support rural health and healthcare. And then we want to talk to you about our latest effort to move the needle within a 1 to 2 year time frame in ways that will enhance access to care and improve quality. Since this is our regular quarterly Healthier Washington webinar, we plan on starting with some level setting and reminders of what we are hoping to accomplish as we advance a healthier Washington. And to do that today, I'm pleased to welcome HCA's new director, Sue Birch.
Hello, thank you, Laura. I'm Sue, and I look forward to this webinar experience with all of you. The work that's been done foundationally over the past 3 years has really been amazing. And I want to talk a little bit more about this initiative. And mostly, I'm still coming up to speed, so we're doing this part for me as well. For those of you on this webinar who are new to this work, here's a quick summary about Healthier Washington. And you'll see from the graphic that Healthier Washington embodies our commitment as a state, from the governor on down, to improve the health of our people and our communities. This diagram shows the ultimate goals of Healthier Washington and encompasses the various projects the state and its partners are undertaking under this initiative. The three areas are ensuring care focuses on the whole person, or being person-centered, improving how we pay for services, or value-based, or paying for value, and building healthier communities through a collaborative regional approach. And a lot of times here in Washington, we refer to our accountable communities of health in this particular area. To achieve these goals, we've got a number of transformational core strategies, including those accountable communities of health and integrating physical and behavioral health care. We're also heavily into performance measures, practice transformation support, and health workforce innovation. The Healthcare Authority is really unique because we are unlike any other purchaser in the state, and it's because we wear many hats. We're the largest purchaser in the state of Washington, purchasing care for over 2 million Washingtonians and spending over $10 billion annually across Medicaid and benefits for public employees and retirees. And soon, the school employees across the state will be coming under the authority. We convene stakeholders around important initiatives, including Healthier Washington initiatives built on the State Innovation Model Grant and Healthier Washington Medicaid Transformation Project. Some of you might have heard about that or refer to that as the old demonstration. And we're dropping the word demonstration because we're clearly in the transformation implementation phase. We create and implement policy and seek to engage and influence the health system broadly across the state. So we want to begin more about HCA's value-based roadmaps. And as the largest purchaser in the state, we've set goals for our spending to drive health system transformation through paying for value. And we recognize that rural communities and providers face more challenges than their urban counterparts. The principles may mean different things to our rural providers. We often end up talking about equity when engaging with rural communities. What this roadmap means is changing the paradigm, and at the end of the day, we cannot create an equitable system of care without focusing on a quality system of care. We need to find a pathway that supports our rural communities' transformation to value-based purchasing. HCA's value-based roadmap sets this vision and goals, and by 2021, in partnership with purchasers, providers, and payers, Washington will leverage its purchasing power to move 90% of its health market from fee-for-service to value-based payments and help drive 50% of commercial and non-state payments into VBP. By so doing, we expect the state's annual healthcare cost growth to be below the national trend. And we're making great strides. Through our paying for value strategy, we will continue to test, improve, and bring scale, shared savings, and cost of care models forward. And we're going to be implementing payment and delivery models through Apple Health and through our PEB and SEB that support whole person, high quality care. A copy of our value-based roadmap is available on the Healthier Washington website, and a link will be shared with everyone attending today's webinar. So let's talk a little bit more about our rural regions and the challenges. And I've shared with many of you that I spent really 3 decades in rural frontier Colorado, so I'm very familiar with rural regions. And being out west, we have a lot of commonalities with our big, wide open states. The challenges that face our rural providers are numerous. Providers face challenges with serving riskier populations. They have higher rates of morbidity and mortality. Typically, our rural communities are older with lower incomes, making the payer mix more challenging. The recruitment and retention issues for our workforce is often challenging, and the rural areas may suffer from primary care and emergency department care shortages. We also know that in rural areas, the operating margins are low and providers tend to be undercapitalized, making innovation difficult. And without reaching economies of scale, the relationships with larger systems have typically not benefited rural providers in the same ways. Under MACRA and MIPS, as the care system continues to shift to value-based purchasing, it's going to become increasingly vital to engage in transformation that re-envisions how rural healthcare can be delivered and supporting our rural providers to do so. And here at the Authority, we're really committed to supporting the rural frontier spaces of our state and to leaning into that whole person health and health equity across Washington. The long-term vision is that we have a system that works best for those who are served by it. Now, I want you to be patient because our presentation today has to go through a few iterations, and just like going out to rural places, it can be sometimes a little bit of an adventure. So let's talk a little bit about opportunity, and I want to share with you a hypothetical scenario to illustrate the opportunity within our state. Jacob and Michael are both native Washingtonians, both are in their mid-20s, and both love the outdoors. They're quite similar in many respects, with one main distinction that has impacted the course of their lives. Jacob is from a small rural town in eastern Washington, and Michael lives in Seattle. Jacob struggles to find work as he grew up in a low-income household and never completed any formal education. Due to the stress of his life, he battles depression and he smokes. He has trouble dealing with healthcare issues because there is limited access to healthcare providers in his hometown. Michael, on the other hand, graduated from a 4-year university and has steady work. Michael did have a short bout of depression, but he was able to access a therapist and get the support that he needed. In general, Jacob is more likely to have less access to a variety of nutritious food choices than Michael, more likely to become obese and get diabetes than Michael, more likely to lack health insurance than Michael, or to seek timely care, and less likely to have access to home care and hospice services. He's also less likely to have access to a primary care physician, a mental health specialist, and a dentist than Michael in an urban setting. and more likely the cost to cost the healthcare system and his community more over his lifetime. So we see a huge opportunity to turn around these trends, and we know that to create true health system transformation across Washington's rural communities, there must be a broader system-wide policy investment that serves as the foundation for innovation. So here's a few key highlights that are important to touch on as we start going further into the VBP strategies. All of these principles follow what is outlined in the VBP roadmap. And on July 1st, 2017, Alternative Payment Methodology 4 converted 16 of our federally qualified health center partners from an encounter-based system to a value-based system. And we're continuing to work on the performance measurement and practice transformation under this model. As we achieve more competence around this model, we expect to keep expanding it over time. Integrated managed care is first and foremost about improving health outcomes and client care. This places care management through a single accountable insurance plan for our clients. It delivers the full array of physical and behavioral health services and health outcomes, widening access for depression and substance use. And shifting the landscape of Medicaid purchasing, the MCO premium withhold incentivizes value-based contracting with providers. It rewards for improvement on a select set of performance measures, such as childhood immunization and wellness, diabetes, depression, and asthma. And the premium withhold totaled $56 million in 2017. Over time, providers will be incentivized to contract on these core measures for improved performance. Representing the single largest investment opportunity in transforming Washington's health delivery system is the Medicaid Transformation Project. And we are creating incentives for providers who are committed to changing how we deliver care. Each ACH region is pursuing projects aimed at transforming the Medicaid delivery system to serve the whole person and use resources more wisely, adding new services, including services and supports for family givers to help people stay at home and delay or avoid the need for more intensive care. And we're creating 2 new targeted benefits that include services that help our most vulnerable beneficiaries get and keep stable housing and employment in support of their broader health needs. Now, for the next step in this journey, I'm going to hand this over to our capable person, Gary Swan, who's going to take us through the work he's leading to explore the rural health system payment reform method that will support the existing efforts to enhance care delivery. And I think he's going to take us through the background, the context, and then the proposal. So please stay with us as we keep journeying through this, because we're getting to the big reveal very soon. Rural places are special, and it takes us a little time to get there, but it's coming in the next upcoming slide. So hang in there with us. Gary.
Yeah, thank you very, very much. First, along this journey, I'd like us to give a little bit of background and context for how we got to where we are. In short, exploring a rural multi-payer model. Under Healthier Washington, their community, and support committee. They identified this key problem statement. The sustainability of rural healthcare delivery depends on fundamental transformation and must consider the unique nature of rural and isolated constituents and scarce resources. The transformation must pragmatically embrace health resource availability and redesign the system with enhanced patient engagement, innovative healthcare interventions, and population health strategies, all leveraging modern technology platforms. So really, as we move into the future, we've had some near-term engagements with payers, providers, MCOs, as well as other key stakeholders, including Medicare, to identify if there's interest around a broader rural multi-payer model. On February 1st, we held a working session on that model, and stepping forward in the future, we're working with those key stakeholders to fully develop a potential model. Diving a little bit more into what we see in our rural communities, it's helpful to draw some distinction between what we see in an urban setting versus in a rural setting. In our rural communities, structurally, the hospital tends to be the central focus, economic center of our rural communities. These tend to be a critical access hospital, and primary care tends to be a rural health clinic. Reimbursement across these provider types are cost-based, and it also means that there's a higher propensity in our rural regions that the critical access hospital owns the RHC. Oftentimes, the primary care physician will cross-staff between the rural hospital and primary care. The ED often picks up care gaps or serves as urgent care for patients. And providers that serve in rural communities more often are responsible for the broader care continuum for the entire community. So that means call coverage of providers, lack of team support, family life, high levels of responsibility and burnout occur in these communities. So how under cost-based reimbursement for Medicare and Medicaid, there's lower commercial penetration, and it makes it difficult for hospitals to operate. More often than not, these urban counterparts, rural counterparts are under more duress than urban settings. So if the rural hospital were to close, it would have ripple effects on our primary care system. They already face in these rural communities challenges around recruitment and retention, and the hospital closure would exacerbate those care gaps and create significant economic impacts. We believe that there's a better solution around aligning this fundamental core of the hospital more with primary care around a broader model that supports managing the health of the population on a longer term. And so that really gets us towards what we're trying to accomplish here. And we've outlined a couple of key goals. I'd like to speak to some of the core contributors in our rural communities. So our providers, they're on the ground doing the work. They know their community. They know what models of care work and how to drive that care. And really, our rural providers wear very many hats to deliver that care. Likewise, our insurers are in touch with the members and providers that they're contracted with, but also bring to the table a different system perspective than our providers. Beyond any model, they know what system supports they need to hit to reach some of those payment reform goals. Our other key stakeholders include associations as well as other community health and partners, advocates. And they really have a pulse on the respective region and community needs. And they really act as our linkage as facilitators to ensure broader alignment with our respective needs and goals. On a state level, we have key roles from Healthcare Authority, Department of Health, DSHS, as well as looking at our federal partners. What we see really is an opportunity for creating more financial sustainability for our providers through a predictable revenue stream, reducing provider burden by sending the same signals on quality, population health goals, and so forth. And the potential for flexible funding for a new kind of workforce in our rural communities. From a plan perspective, really an opportunity to create value savings accrued across this model and sharing in that with our providers. and really protecting against some of the double payment for given services. As an example, getting labs in your rural community and then going to an urban community and getting the same kind of labs. Our other key stakeholders, we see that there's, most notably through our associations and other community advocates, there's a unique opportunity to really align and invest in new types of strategies that support these rural communities and help develop collaborative frameworks that advance these goals. And really, at the end of the day, what we're talking about is transforming this health delivery system in our rural communities to work better for the people that we serve. In terms of value-based payment reform, I want to take a quick walk through a scenario. Imagine, according to Jacob and Michael, that one child has asthma, the child has asthma and depression. So in a traditional system, the PCP would handle all of that care. The client would come in, see the PCP, they perform a comprehensive assessment. Maybe they would prescribe an asthma inhaler, recommend some more exercise, and provide some contact information for behavioral health specialists. But the PCP would be the primary point of contact, would provide all of the follow-up and provide face-to-face visits with that client. What we see as an opportunity is in a transformed system that the PCP would perform his assessment and then would hand off that client or that patient to a nurse care manager. The nurse care manager would perform an assessment and develop a care plan for case management that integrates with the doctor's care plan, would refer the case manager would refer or call in the pharmacist or RN to review asthma or other medications, perform a depression screening for behavioral health, and work with behavioral health specialists to develop a care plan. Also, the case manager would help connect a patient with social supports in the community and determine if there's a need for identifying youth programs or if there's a need to go directly into the home to support the client. Really, at the end of the day, this is about developing a care plan that can be coordinated with the physician and that the primary point of contact becomes your case manager, and the patient is able to work with that case manager to develop an action plan that works for them. And really, though we're talking about potentially more people touching that client, it means lower costs because it's avoiding that face-to-face encounter with the physician, allows for them to develop a care team and have that patient interact with the care team, and improves the overall quality in moving towards whole person patient-centered health. And it really allows the doctor to free up some of that face-to-face time to see the most critical clients that need his care. On the longer term, what we're talking about is creating sustainable solutions for maintaining and increasing access. And by having the client or having the patient work with the care team and rewarding the rural provider based off of managing the health of the population, it allows the provider to scale those services at an appropriate fashion that's needed for that community. So that may mean scaling up certain kinds of services around a care team and scaling back potentially other services, but create flexibility in allowing the provider to address the specific needs of the populations that they serve. And at the end, what we're really talking about here is delivery system transformation. We're talking about shifting the way that our rural providers interact with the clients that they serve and supporting them in that transformation as aligned with the types of investments, practice transformation investments that we've already engaged in. So that includes alignment with the Medicaid Transformation Project, alignment at a national level with MACRA and MIPS, as well as other practice transformation supports. For our clients, what this really means is empowering them with the tools and knowledge to manage their own health, but really engaging them in the local health delivery system and making sure that they are getting the care earlier in the care continuum and identifying more appropriately how to interact with that local healthcare delivery system. What we've been talking around this entire session is around a rural multi-payer model. What we see implemented nationally and endorsed by Medicare, and important to this work as a key component is Medicare participation. We can glean examples from a Maryland model, Vermont, as well as Pennsylvania. So the Maryland model and the Pennsylvania model are essentially budgeted models of care for hospital-related services. So this speaks to inpatient, outpatient services. They take total patient revenue across all participating payers, set a rate based off of that client attribution for participation from each payer, and set trend factors that apply to that budget going forward in the future. And really the impetus behind setting these budgeted approaches is focusing around practice transformation at a local level. And in Maryland, there's a focus around a care redesign program. So focusing on leveraging those types of resources in a more innovative ways to engage with the clients they serve, and in providing financial flexibility and reliable payment to do so. In Pennsylvania, for participation in any model or participation in the pilot, rural hospitals have to submit care transformation plans to a rural redesign center. So this means that they have to articulate prior to participation how they're going to transform the care that they deliver in their community. So the Maryland and Pennsylvania models really speak to budgeted approaches for inpatient, outpatient services for a hospital. The Vermont model takes a bit of a broader approach by developing an all-payer ACO construct. And what this basically is taking a broader suite of services, establishing a budget for those services, and trending those services. Again, the focus really is on practice transformation under the accountable care, multi-payer accountable care that's established in Vermont. So focusing on substance use disorder, suicides, chronic conditions, and access to care. The last piece that I'd really speak to in terms of the types of examples that we see nationally is in terms of a governance kind of construct. In all of these models, there is a multi-member panel that includes payers, providers, and other key stakeholders that participate in shaping the budget, in shaping administrative needs, as well as practice transformation for the model. So there is an administration overlay across each of these models that is a collaborative framework. So based off of our engagements, early engagements under Payment Model 2, and engagements with the Health Innovation Leadership Network through the Rural Health Innovation Accelerator Committee, we've identified a couple of key pieces for inclusion around a type of approach that we see would be endorsed at a national level. Structurally, that would include hospital-related services, so inpatient, outpatient services, including ER, observation services, ancillary services. For our critical access hospitals participating in the model, that would include swing bed services. So it starts to get at some of the long-term care component pieces. On primary care, we also include rural health clinic services, as well as PCP or physician-related services that are offered within the hospital. What this means for the hospital is that we would establish a baseline budget based off of total patient revenue, trend that budget according to a reasonable market basket trend factor. We identify payer allocation of that budget. So based off of a health services area, determine the attributed clients that fall to that hospital and identify payer allocation based off of payer participation. We would perform retrospective adjustments of the budget and reconciliation. So what we're talking about here is truly in a budgeted sense, that we would have payments as they traditionally have been made by the provider and the payer, and that we would perform a budget reconciliation to that established baseline budget trended. And we would adjust for factors such as if there was an emergent event in the region, that we would adjust the budget. If there were market changes, so clients are seeking service outside of the region, that we would make appropriate market adjustments. And also if there were those kinds of outlier scenarios, that we would have adjustments for high cost outlier events. Prospectively, we would adjust the budget based off of, first and foremost, quality performance to a select set of measures. We would be seeking to align that performance and that measurement with the types of work and efforts that are currently going on in our rural regions. So recognizing where our rural providers sit now and where we want to go in any kind of population health management perspective. We'd also adjust the budget based off of payer participation and the clients that fall into that health services area. And then there'd be an encounter-based payment piece. So for those clients, think in terms of a holiday community or in seasonal swings in terms of the care that the hospital provides. Those patients or clients that come in and visit or need services from the hospital that don't fall within the health services area would be reimbursed as they traditionally have been under current contracts. For primary care, it's converting patient revenue to a per member per month amount, prospectively adjusting that per member per month amount based off of quality performance on a prospective basis. And then again, there's an encounter-based payment piece. And ideally, we would like to build a total cost of care component that overlays all of this. And really that's to start to get at the notion that we want to drive and coordinate care with the clients in these rural regions and make sure that we're more adeptly managing the health of that population. So I'm going to pause for a moment there and check to see if we have any questions that have come in from our panel.
We should move along.
So in terms of our engagement process, as I noted earlier, we had a working session on February 1, and in that session, we reviewed this model and talked through a couple of key buckets, which included practice transformation, scope of service included in the model, fiscal concerns, as well as quality performance pieces. We are planning a follow-up working session, and that will essentially focus on our key goals. So making sure that we are, as a collective, talking in the same direction and understand what it is we're trying to accomplish under shifting payment for our rural providers. From a state side of things, we are staffing up in very short order to meet the need for a 2018 development timeline. So this means during 2018, really working through fundamentally structural pieces of the model, which include fiscal components, as you know, we've just outlined here in a strongman capacity, quality performance pieces. And I think fundamentally, what we're talking about here is alignment of the payment systems that match what we're trying to effectuate through practice transformation. That meaning that we're trying to leverage and accelerate the practice transformation under the Medicaid Transformation Project and not supplant the type of activities that we currently see going on in our rural communities. This fiscal change to shifting to managing the health of the population is a multi-payer focused piece that gets our payers aligned on the way we pay and the way that we reward for the care delivered, and focusing on the practice transformation and allowing that practice transformation to occur in our rural communities. So ideally, we'll be working from some of these early strawman development pieces and stakeholdering in the very near months. Looking very briefly at a high level over the year, it's our intent to engage through November on developing this proposal with a fundamental focus on the early stages of this around fiscal components of a potential model. So that would include scope of service, that would include budget types approaches, how we're handling risk, and so forth. As well as towards the latter parts of the month, through August and November, really focusing on the quality performance pieces and alignment with our other practice transformation initiatives. We're seeking to hold our next working session on March 15th. That invitation will be sent out today. And additionally, I'd like to add that we have made a request at the February 1 working session for letters of interest to participate in that March 15th working session. We have had strong response from both our payers, providers, as well as other key stakeholders in participating in that ongoing progressive working sessions. And we expect to continue that process going forward over the coming months. We're also targeting here a development timeline that ends in January of 2019. So really spending this year to reach agreements and identify a potential model and have that finalized by January of 2019. And that would include Medicare participation and alignment in a potential model. So that's an overview of our rural multi-payer model on our rural efforts. And we'd like to open it up for questions that we received from the panel.
Great, thanks, Gary and Sue. We are now opening this up for questions. We have received many questions through the comments panel, so please continue to submit those now. But we have received some throughout the webinar that I'd like to address now. Gary, you really clearly articulated sort of the different principles that are going to be applied, as well as the straw person model. But really, what's the key when it comes to a multi-payer model? And that's it's in that multi-payer. We need Medicaid, Medicare, and commercial. To that end, what has been Medicare's interest and engagement thus far?
That's a really good question, and thank you for submission. You know, in our rural communities, we see that our rural providers want to do value-based purchasing. Our commercial payers and MCOs want to implement value-based contractual arrangements, but we just don't reach economies of scale from a rural perspective. And to really get at that, we need to have multi-payer participation in the model to get a big enough chunk of the payer mix to make it worth the while for our providers to shift the way that they are delivering care. And as a specific example, in particular on Medicaid and Medicare, if we're talking about cost-based reimbursement that is driven by utilization of services, if we move to models that incentivize management of the health of the population and essentially draw down that utilization, it has systemic impacts unless we have alignment between Medicare, Medicaid, and other commercial payers. In terms of Medicare interest in this model or this exploration process, Medicare is very interested in participation. They're very interested and excited by the amount of work that Washington has shown and the level of interest that we've expressed thus far. So we think that we have a unique opportunity through our SIM engagement in the last year of the SIM grant ending in January of 2019 to really leverage that relationship and develop a rural multi-payer model that gets us to a next stage with Medicare.
Great. Gary, I think what you've been hitting on is really important, in that this model really is a way to make fiscal change to move to population health. Can you speak just in real life terms what that means at the end of the day?
Yeah, and I think I would really like to bring us back to the goals that we have outlined for this work. And those goals were really informed by HCA and Medicare interests, as well as the learnings that we've gained through our engagements with the Washington Rural Access Preservation Group, as well as with our federal partners, Medicare. And that's really value-based payment reform, shifting the way that we are paying for services and rewarding for outcomes and value, and doing it in such a way that we're supporting our rural providers in this transition in a meaningful way. And what that means is sustaining access and maintaining the level of services. To get there, we need to have delivery system transformation, and we need to have patient engagement in our rural communities. I think that that's the core of what we're talking about.
Great. Sue, paying for value, access to care, quality care, healthier populations, that sounds really familiar and aligned with the Healthier Washington work that this state has been driving toward for 5 years or so. Can you speak a bit to how this model, and expanding on some of Gary's comments, can you speak to how this model can really drive these broader aims around well-being and health, as well as what other roles of public health community-based organizations could be?
Yeah, so Laura, the person that submitted this, thank you, because I think we in America are really coming to grips with having to make sure that we have the right proportion of medical spending and to social spending. And so it behooves us to think about, as we continue to build out healthier cultures in our rural areas, how we've been basing and standardizing in the primary care arena. We now are in the standardizing and really solidifying the behavioral health integration, and we need to keep pushing to assist with the social services that are evidence-based. So communities that need strengthening in things like home visitation or access to reproductive health care or greater employment supports. These are things that in our rural areas with the workforce centers and with our community partners, public health and social services can play an enhanced role. And by realigning the financial incentives, we'll have dollars that can be redistributed back into those supports that are so critically important. And by that, Laura, we're going to be able to get to a better balance of not just promoting better health outcomes, but also move individuals into this focus on well-being. So we will be working with our accountable communities of health and our public health partners at things like harmonizing. If we've got public health improvement plans that are filed, we also want to make sure that those are in line with our hospitals where they have filed their community benefit needs reports. So we want to make sure that these things get harmonized at the rural area and that we're making much greater use of the supports that are out there in our public health and community partners.
Thank you. So we've gotten some comments about how this appears to be quite ambitious. and tackling any sort of rural health delivery system transformation will be an ambitious endeavor. This does feel like jumping into the deep end of the ocean. Gary, can you speak to how we're engaging stakeholders, including providers, in shaping a model that meets them where they are, and what kind of flexibility there will be or not be in achieving the goals?
Yeah, and thanks for that question. So we agree that this is ambitious, but we think it's also very necessary and timely to address our rural communities in alignment with the types of efforts that we've already initiated under Healthier Washington, and really see this as an extension of that already initiated work that's underway. In terms of engaging our stakeholders, we have, again, asked for letters of interest. That doesn't mean that those that submit letters of interest by close of business today will be working solely with those, but we want to make sure that we have a broader engagement strategy with all of our rural providers and stakeholders in this effort, and are willing to ensure that those that are interested get folded into this work as interest is expressed. We hope to go through a series of working sessions to develop the model, which in the front end will be around setting those goals, talking about the fiscal components of a model, as well as talking about outcomes and alignment pieces. In terms of flexibility, I really direct us to CMMI guiding principles for Medicare participation in this. Well, there are essentially two tracks. One, we adopt an already developed CMS model. Two, we collectively collaborate and develop a Washington state specific model. And CMS is willing to engage and excited about our development process in that. So following this session, we'll make sure and respond out with those principles that have been identified by CMS.
And I just want to add, this is Sue, I just want to add to Gary's comments that, I remind you that we have extraordinary strength in the rural areas because it's scale. We have a manageable scale. We have a lot of interest because I think our provider partners and many in the rural areas already work in this very whole person way. And so I think there's a lot of excitement about let's try a solution. And with our federal partners and innovators ready to go forward, we stand ready here at the Authority to launch into this very exciting, ambitious work.
So just to get down to brass tacks, this looks like a global budget approach. How is this process going to address providers being ready to take on different levels of risk?
So I think we've heard in all of our sessions that when you've seen one rural community and one rural provider, you've seen one rural community and one rural provider. So I think that's a recognition that our rural communities are at different stages. We are very interested in bringing in those that are willing and able early on, but we do want to recognize that for us to shift the broader landscape of our rural communities, it needs to be something that addresses all of our rural communities. That being said, that we will ensure that there is phased implementation as well as other types of support that help those that need that kind of support get to the type of capacity and ability to adopt the models that we develop.
Thanks, Gary. Kind of to dive again sort of into the weeds of the model, how are we going to target services and either carve in or carve out specific, potentially even higher cost services into or out of this model? What kind of considerations will be taken there?
Yeah, that's a really good question. So I'd first and foremost like to direct us back to the hospital as a central entity in rural communities. I think that there's a more opportunity statement around integration with primary care and population health management, notably behavioral health management, as well as developing care teams. But if we're not collectively addressing that with the hospital-related services, then there's going to be a fundamental gap in these rural communities by incentivizing population health on one side and not integrating that with what the hospital sees. We see that as a significant challenge. With that being said, I think there's a recognition that the rural community, it is just that the community is the central entity that provides all the types of home-based and community supports, as well as emergent services. So I think that there's an opportunity to talk about how can we collectively collaborate and identify either inclusion of those types of services in a potential model, or build the model in such a way that it aligns with the activities that we currently have invested in or underway in these rural communities.
Thanks, Gary. The workforce, as you've alluded to, is a huge component of this. And we received two questions or two different kind of threads along these questions. So first, how might this model, or how would we have to address or consider shortage of providers in rural areas? How are we considering those shortages, and how might this this approach even address some of those capacity concerns?
Yeah, that's an incredibly important question, and I think that the solution is not just a silver bullet, but it's going to be unique to each community's needs. Part of the solution, I think, is telemedicine supports, building out rural networks of telemedicine support, potentially localizing a provider in one rural region and having that support be networked across other rural regions or with an urban setting. The other piece, I think, is around fundamentally our workforce piece under the Medicaid Transformation Project. So identifying those paraprofessionals or mid-levels and providing the types of retraining or supports that help get to development of a care team for our rural communities. That also includes thinking a little bit outside the box of meeting the client or meeting the patients where they are. So outside of the four walls of the hospital, extending services to those community resources or those community collective gathering places where we can start to really engage our rural communities. So I think that that's part of the solution. On the other side of that, making sure that we're working with our educational resources, with our schools to identify types of retraining programs that help to fit those needs.
Thanks. So you spoke a bit to this in just kind of building capacity, and we know that other rural multi-payer models across the nation have really relied heavily on clinical practice transformation in order to build the necessary skills and capacity to move in this direction. Can you speak to if we are successful in implementation and launch of this model, what kind of practice transformation supports providers might expect to see?
Yeah, I think that there's a lot of different opportunities. I think principally we want to make sure that we have alignment with the practice transformation efforts that have been put in place through the Medicaid Transformation Project, as well as through the types of national HRSA granting supports and types of efforts that we see being implemented through our rural collaboratives and associations. For the clinical practice transformation piece, I think that there is the potential, there are clear gaps in our rural communities. Take for a specific example, having the type of support that can identify data elements and manage your health of your population and help to work with your provider in providing them not the data, but the information to manage the health of that community. And I think that there are opportunities for us to potentially collectively collaborate, both from a payer and a provider perspective, to address some of those gaps. And those types of things will be borne out throughout our working sessions and engagement process.
Great. And to close us out, I'd like you to speak a bit more to the working sessions. So you spoke to the February 1st meeting. Working sessions will be true working sessions among payers, providers, and others moving forward. How can people get involved in those working sessions? Is it appropriate for everyone to come to those? If they haven't submitted a letter of intent yet but want to, how do they do so? And how can folks stay engaged even if they do not come to those working sessions? In 2 minutes.
Yeah, so these will be true working sessions. It may not be appropriate for all stakeholders to participate in every working session. And if you connect directly with us, we'll help to manage what is meaningful for you as a stakeholder, but we also look to have that direct engagement. The easiest way to get engaged is to reach out to us through HealthierWA at hca.wa.gov. We are very interested in having a broad letter of interest response that includes not just our payers and providers, but community advocates, as well as other key stakeholders. So we would look for and be happy to receive a letter of interest support from all who are interested in this type of work.
Great. Thank you, Gary, and we look forward to future conversations about this. There are many ways to join us in the work going forward, so make sure to visit our homepage for regular updates, and especially make sure to join our Healthier Washington feedback network, which we use regularly to share opportunities to provide comments on our efforts and engage in activities. In addition to the quarterly Healthier Washington webinar series, we do have a Paying for Value series currently happening. The next one is March 14th, and will focus on the success of the Accountable Care Program, or what some may know as UMP+. Everyone participating in this webinar will receive an email with more information. Thanks to those who joined the webinar today, and thank you for all that you do to achieve a healthier Washington.